Hello, my name is Sarah Erickson, and the title of my project is Education with Impact. My committee includes Dr. Snell, my chair, Dr. Brunworth, my second reader, and Marina Presley as my community member, a clinical nurse specialist at the facility where the research took place. I wanted to start by explaining how this project all began. While working in the intensive care unit, I witnessed patients being referred to as their substance issues rather than as people. This made me question how that may affect their care. My scholarly project aimed to educate ICU nurses on the impact of their care on patients with substance abuse issues. Nurses trained in the field of mental health are more prepared to care for patients with substance abuse issues, with a better understanding of interactions. Incorporating education that brings mental health into the care of ICU patients may decrease poor perception felt by patients with substance abuse disorders. The public often think of healthcare providers as being compassionate towards people with substance abuse, and this is not always the case. Several studies indicate a poor perception of these patients. Advanced education is a significant predictor of stigma with a 95% competence rate, indicating knowledge combats stigma. Stigma related to mental health is a well-known issue, and educating staff on the care of these patients is one way to combat the stigma. According to the National Institute on Drug Abuse, substance abuse costs our nation as much as $600 billion a year. Helping patients to obtain and commit to making changes may only be possible if the patients feel cared for and understood. This may be possible with better training for providers on patients with substance abuse issues. Not to mention the high number of people with substance abuse issues. In 2017, 19.7 million Americans struggled with substance abuse issues. 10 to 15% of healthcare providers experience substance abuse misuse. Themes in the current literature were noted as healthcare professionals' stigma associated with substance abuse issues, the impact of stigma on patient care, and education's impact on perception. Many of the studies available demonstrated positive effects of education as evidenced by participants' improvement in pre- versus post-test surveys. The weakness of several of these studies is the small sample groups. Results cannot be generalized if they occur at a single institution, have singularly focused patient groups, or have a sample group that is not translatable to the general population. Limitations observed in the literature included limited evidence that learning has taken place with evidence of long-term learning. Long-term learning would need to be followed up. That could be evaluated with a 3-month post-test, which was part of this project's original plan. Irvin Goffman, a social scientist, had many works on social behaviors and our presumption of people. He describes 3 types of stigma: physical deformities, character, and tribal, and describes how life experiences help us to learn and determine what is normal. The perception of class and societal identity affect stigma, and how society is more a voice for the group. This is a question for healthcare workers. The stigma placed on patients with substance abuse issues Is that the view of the provider or of society? People may try to conform and change the stigma assigned to them through behavior. However, the people that attempt to improve themselves are often left with emotional scars from the stigma itself. Goffman does elaborate on a solution as a way to break the stigma. He explains that the normal person who is becoming wise can have experiences that cause a change of heart, changing the perspective of the stigma. Promoting an experience with education is how this theoretical framework impacted my project. I wanted people to really see these patients as people rather than the stigma of the substance. This project plan evaluated the nurses and care partners using the Drug and Drug Problem Perception Questionnaire, DDPPQ. The hypothesis was that negative comments made by staff could influence the opinions of other staff members, resulting in a different first encounter experienced by the patient. Negative comments can cause the staff to act differently than they would without those negative comments. The DDPPQ allowed for a numerical way to measure a baseline and evaluate if the participant's perception was changed with the education. The data that was collected was done anonymously with PIN codes used to identify each participant, so a change in score could be determined. Participants would more likely answer questions honestly if anonymity was maintained, resulting in more honest answers. Evaluating providers' perception of patients with substance issues is not an easy task. I first needed a reliable way to measure their perception. The DDPPQ proved to be a reliable tool for this task, and with the tool, I could assess the perception with a numerical value that was capable of measuring a change. So now I had a way to assess an honest perception of how providers felt about patients with substance abuse issues. Then I could educate and help providers to understand that substance issues can happen to anyone, and no one wakes up and makes a decision to have a substance issue. I could then assess a numerical value to see if there was improvement from baseline scores. The plan was to assess the staff in an intensive care unit. The subjects included in this project were 78 registered nurses and 16 certified nurse assistants between the ages of 20 and 62 years old. The education levels varied from certification as a nurse assistant to a master's degree. The staff on this unit at the time of implementation had changed quite a bit. During the planning stage, the unit had staffed 124 registered nurses and 26 certified nurse assistants. To accurately evaluate the data collected, a statistician was consulted, who first ran a Kolmogorov-Smirnov test to ensure both data sets were normal distributions. Neither set came back with significance below 0.05, showing it did not violate the assumption of normality, allowing for a paired t-test to be assessed. The paired t-test came back with a significantly less than 0.001, giving evidence of a change from pre-test to post-test. The variability was considered using the pre- and post-test scores with a total sample size of 64. The degree of freedom was 63. The effect size was 0.712359. And the standard deviation was negative 6.953. The standard deviation allows that a decrease in the score was seen, thus showing improvement with a lower post-test score. Collecting the data anonymously prevented this project from being able to have a control group. Providing staff with an educational opportunity to improve their self-awareness of biases was key in improving the perception of patients with substance abuse issues. The total number of survey participants evaluated for this project was 64. Of those surveys, 17 showed no change in score. One survey did show a 3-point increase, which would be a negative change from baseline, as improvement is seen with score decreases. The score changes seen were very broad and were from 0 to 45 points. This graph depicts the pre-test scores in yellow and the post-test scores in green. Scores that are higher show more bias than lower scores. Learning was effective with this education for the majority of participants as evidenced by the decrease in scores. 46 of the survey scores that were compared showed a decrease, indicating that the education was impactful. The answer to survey questions may have been altered to provide the response the participant thought the researcher was looking for. This is sometimes referred to as social desirability bias. Providing the answers that are thought to be desired alters the results of the research. Time limitations in a busy intensive care unit may stress participants to rush through the answers to get back to patient care without responding to the survey appropriately. At the time of collection, in October of 2021, the staff was highly stressed due to high number of patients with COVID. The roles of nurses and nurse assistants were strained from the stress and the limited staff. Given the situation, the answers to the survey questions were likely affected. Post-education surveys are unable to provide insight into the question of whether long-term learning took place. Long-term learning was not evaluated because the post-education survey was obtained directly after the education. And by obtaining the post-education directly after the education, the information was fresh on the participant's mind. This project's goal was to decrease negative views of patients with substance issues, thus providing better care for those patients. The initial plan was to provide a baseline survey, provide education 2 weeks after with a post-education survey, and evaluate with a survey 3 months after the education. The initial plan was opted to change due to the high staff turnover rate in the unit. The staff in the ICU were leaving at such a rate that reevaluating staff after 3 months proved unattainable. The data collected showed evidence that the education presented resulted in a lower score, indicating that learning was effective with education. More than half of the staff that was educated showed improvement in scores based on the education piece presented. The score changes from baseline were broad and ranged from 0 or no change to 45-point decrease. The lower the score signifies less bias. Each participant completed 2 surveys, a baseline and a post-test education survey. When compared, 46 out of the 64 participants improved their scores. There were more obstacles to this project than anticipated due to the pandemic, and the barriers noted were time, incomplete surveys, and outliers in data. Time constraints were related to the critical nature of COVID patients on the unit and the rate at which staff were leaving the unit for other positions or nursing in general. The outliers could be related to the stress staff was experiencing due to the pandemic. One survey increased post-education, indicating more bias after the education, and this may be that individual got the surveys mixed up. All surveys were completed anonymously, and therefore that theory cannot be confirmed. The stigma that substance abuse patients experience related to receiving health care can be significant to their recovery. For quality care and the safety of patients in this setting, further education is imperative. Improving the care of these patients may result in a decrease in the number of fatalities and readmission due to substance issues. If patients do not feel cared for or understood, they will not seek care or continue care, which suggests the importance of adequately training staff in the area of mental health and substance abuse. A reporting system called ODMAP, Overdose Detection Mapping Application Program, shows that the early months of the pandemic brought an 18% increase nationwide in overdoses compared with those same months in 2019. Implementing proper education for providers could prevent these patients from being admitted repeatedly for substance issues. If substance abuse issues cost our nation as much as $600 billion a year before the pandemic, that cost has likely risen. Decreasing the stigma associated with substance issues felt by the patient decreases the chances of future hospitalization and the cost to the hospital or state. If not for the cost, family dynamics could also be considered. For example, the emotional damage caused by a loved one with substance abuse issues. This quality improvement project was aimed at improving the perception of clinical staff with education by evaluating using the DDPPQ instrument. The instrument showed high reliability for retesting purposes, and the method of collection was concise. The data analysis did show that learning took place with education, as evidenced by the results presented. Barriers and unintended consequences were noted at the time of collection. Due to the pandemic, changes in score from negative change, no change, and substantial change, and need further investigation to evaluate the impact on this project. This project was planned prior to the pandemic and did not incorporate the obstacles that came along with COVID. Long-term learning was not established due to the high turnover rate of staff on the unit and the difficulty in locating staff at 3-month post-education. This needs further investigation. For this project to obtain better data, completing the survey and education as originally planned would give better insight. Implementing this education and the surveys in the original timeline could eliminate some of the barriers and evaluate if long-term learning was observed. Should this same project be implemented even at this time, the results would vary. This program has taught me the value of education, not just furthering my own education, but the impact education can have on the environment of patients and the care that they receive. At this time, I would take any questions. This is a list of references that were used for this presentation. I thank you very much for your time, and I hope that this has made an impact on the way that you see patients with substance abuse issues. Thank you.